I think states are making a lot of strides toward health equity. 5 years ago or so, this was new for some states. However, what we saw at Children's Safety Network is that many states, in fact, have been involved and passionate about and working on and thinking about equity for a number of years.
One big thing that many organizations that have been focused on a particular issue, in our case, injury and violence prevention, is the increased focus on multi-sectoral work and realizing that housing, education, absenteeism in schools, it's all tied together.
Welcome to this Children's Safety Network conversation about achieving health equity. I'm Maria Katradis, Senior Training and Technical Assistance Associate at Children's Safety Network, or CSN. CSN is a project of Education Development Center and is funded by the U.S. Department of Health and Human Services through the Health Resources and Services Administration's Maternal and Child Health Bureau. The World Health Organization states that health equity is achieved when everyone can attain their full potential for health and well-being. We are still far away from achieving health equity in the United States, especially when you consider the health disparities we see among different groups of children. For example, data show that peak suicidality in Black youth and young adults is much earlier than in their white counterparts. Sudden unexpected infant death also happens with more frequency among Black and American Indian Alaska Native infants than among white infants. Many states are working hard to eliminate the social and structural barriers that prevent access to full health equity. In the past few years, for example, we have seen an increase of states focused on addressing health equity in CSN's Child Safety Learning Collaborative. States are focused on integrating the communities they serve in planning and implementing evidence-based and evidence-informed child safety strategies in a culturally responsive and respectful way. These examples reveal that health equity is within our grasp and that state health agencies play a critical role in improving outcomes. In today's episode, I moderate a discussion between Jennifer Leonardo, Director of CSN, and Rich Hamburg, Executive Director of the Safe States Alliance. The Safe States Alliance is a national nonprofit that aims to strengthen injury and violence prevention practices at the state level. The conversation begins with a focus on how CSN and the Safe States Alliance are prioritizing health equity. Then we discuss what we are seeing at the state level and offer ways that Title V agencies can design interventions that reduce disparities in youth health outcomes. So thank you for joining us today. Would you like to introduce yourselves? Rich, we can start with you.
Sure. I'm Rich Hamburg. I'm the Executive Director of Safe States Alliance, a national injury and violence prevention membership organization.
Thanks for joining us, Rich. And Jennifer?
Hi, my name is Jennifer Leonardo, and I am the Director of the Children's Safety Network at Education Development Center.
Wonderful. Thank you for joining us. I'm excited to spend some time with you today discussing health equity. I'd like to read a definition of health equity so we're all on the same page. The World Health Organization defines health equity as the absence of unfair, avoidable, or remediable differences among groups of people, whether those groups are defined socially, economically, demographically, or geographically, or by other dimensions of inequality. And later, health equity is achieved when everyone can attain their full potential for health and well-being. What does achieving health equity and child safety outcomes look like for you where you stand? Rich, we can start with you.
Sure. At Safe States, health equity is central to injury and violence prevention, the work that we do. Generations-long social, economic, and environmental inequities resulted in a disproportionate burden of injuries and violence for people of color. So addressing injury and violence prevention is inextricably linked to equity. For Safe States, we're committed to ensuring a diverse, inclusive, and equitable workplace for our members, staff, partners, and those that we work with most closely. Overall, equity is the foundation of what we do in terms of the core components of a model injury and violence prevention program. We also partner with other organizations that share our values and advocate for policies to advance equity and injury and violence prevention and promoted programs that are community specific. For example, we recently worked on a tribal opioid response resource toolkit, and actually one of our main sources of funding through the Centers for Disease Control and Prevention is now named Creating Safer States by Advancing Health Equity, Injury, and Violence Prevention. So it's central to everything that we do.
Thanks so much, Rich. Jennifer, could you share about the Children's Safety Network?
Sure. We're very much aligned with Rich, and Safe States is a key partner of the Children's Safety Network. We see health equity as a central part of all the work we do. It is truly our vision. It is a guiding star of the work that we have been doing over the past years, and we're always looking for improvement and innovation in this area and reaching wider populations and wider geographic regions across our nation. It's a strategic priority, a commitment, and a passion. Our team sits down every year and we intentionally think through what are the strategic goals? How can we advance equity? What can we do with the resources that we have, the partnerships that we can build, the collaborations that we can have in place from the local context to the states? We lead and we participate in a number of national panels and work groups that examine the impact of racism and discrimination in public health and its impact on child safety from birth through age 18 in our country. We provide technical assistance to state and jurisdiction health departments across the nation. We help them to identify inequities in access to services. We help them to adapt programs and resources so that they equitably reach diverse populations and they are culturally relevant. And we ensure that we are always thinking about how to advance health equity with the engagement of community members and those with lived experience. There are a number of resources on our website that can speak to health equity and are available publicly, including a number of webinars for different populations in different child safety topic areas.
I would love to hear more about how you have infused health equity into your day-to-day activities at Safe States Alliance and the Children's Safety Network. I'm wondering about how you train staff and partners to examine social determinants of health and structural barriers to health, and how those ideas manifest themselves in the internal conversations you have about child safety.
So at Safe States, we instituted an anti-racism and health equity work group a number of years ago to engage members and staff in open discussion on a variety of cross-cutting topics to build awareness and dialogue internally and externally. The group makes recommendations for strategic opportunities to incorporate an equity framework in the work that we do in our programmatic and policy activities, and identifies opportunities for collaborating with public health partners. Over the years, it really has become more of just an open space for our members to discuss, tough topics. We started maybe 5 years ago. We have a series of weekly staff meetings where we have open discussions on different topics, and more we started to talk about issues around injustice and diversity and equity. And our staff really appreciated those open discussions. And then we brought that to the membership, and even some of our partners have come in and participated. So I think that's vitally important. We also instituted a seed grant program last couple of years to implement innovative and equitable approaches to injury and violence prevention, including training and support to rural agricultural workers in Hawaii, developing swim education curricula to meet the needs of the most vulnerable. And we're continuing to do that this year as well. We have a kind of a seminal document of ours on building safer states that we recently updated and now titled Building Equity into Safer States, which provides guidance on integrated health equity across the core component of model injury and violence prevention programs to ensure that resources and decisions are based on the unique needs of individuals and communities. And then finally, we partnered with over 50 national organizations and the National Cooperative for Health Equity to produce a vision and a call to action to broaden the reach of injury and violence prevention programs by reducing health and racial inequities through community engagement, partnership initiatives, and policy strategies. So, there's a lot of policy work and, going on in the state and federal level in the space of health equity. And I wanted to bring groups together to focus specifically on how it impacts injury and violence prevention. And those 50 groups that I reference include EDC and Safe Kids and National Network of Public Health Institutes, American Public Health Association, Trust for America's Health, just a lot of the partners that we normally work with who either specifically focus on injury and violence prevention, or injury and violence prevention is an important component of a broader agenda.
Thank you so much, Rich. As a member of the Safe States Anti-Racism and Health Equity Work Group, I've been part of these cross-organizational discussions about health equity. And I would love to hear a bit more from your perspective, Rich, about how the work group influences day-to-day conversations at Safe States.
I participate in a lot of them and get the feedback from those meetings. And we've tended to use that group as a sounding board also as we were looking at other documents like the Building Safer States one. And, we just want to make sure that in our identification of policies, our identification of programs, that we're creating safer states by advancing health equity, injury and violence prevention. We want to make sure that that we're utilizing, that group as a sounding board and also the expertise that comes from it, and to take some of the hard discussions that are taking place to also bring that back to our board and bring it back to our staff so we can have similar conversations.
Jennifer, could you tell us a little bit more about what's happening at the Children's Safety Network?
We started some time ago in our weekly team meetings to have an agenda item to be able to share about any cross-cutting issues, and health equity is the salient issue that comes up. And so it's a real opportunity in a standing meeting to be able to have that open space, as Rich was also talking about over at Safe States, where the team can come together and say what they're hearing, what they're experiencing, new resources that are coming out. Another thing that we recently did was to say, let's dig a little deeper and let's see where we can increase our skill development along this area. So I'm excited to share that one way we're doing this is by intentionally having additional trainings for staff to become confident and competent in accessing national data sets, namely the CDC, Wonder, and Whiskers, and YRBS data sets, to be able to have everyone feel more comfortable to access this data more in real time, and to be able to have everybody on the team at all line levels to be able to offer this in their conversations with state and jurisdiction health departments, and for their own knowledge increase in professional development. So rather than having a few select people doing that, the idea is the more people who can do this, the more it will influence all of our work in a positive way. We also coordinate a national advisory board, and this is the Children's Safety Now Alliance. In the vision of the Children's Safety Now Alliance, we have that we are working to reduce deaths, hospitalizations, and emergency department visits among infants through adolescents and young adults age 19 through equitable approaches. And so this is a group of 36 member organizations, including federal and state agencies, hospitals, universities, and community-based agencies that have a national focus. So we come together twice a year as a large group, and then quarterly as a steering committee, to think about equity, to look at the data, to look at the social determinants of health, and to ask ourselves, what are we seeing at the national level, and what are we hearing from the states? And how can we strategically come together to develop new resources or provide additional technical assistance in this space?
Thank you so much, and thanks for bringing us over to the state level. So both of you work with state partners on youth injury, violence prevention, and child safety. How are states making strides towards health equity?
I think states are making a lot of strides toward health equity. Back about 5 years ago or so, this was new for some states in relationship to some of the terminology. However, what we saw at Children's Safety Network is that many states, in fact, have been involved and passionate about and working on and thinking about equity for a number of years, but they may have been calling it something different or not quite understanding, what is the new framework or what should we be doing? So that was really a place that we needed to start to say, let's come together and let's identify and define what health equity is. Let's look to what states have already been doing to inspire and motivate them to build confidence. There are some states who have been looking at heat maps and looking at data for a number of years. For other states, that was new. So how do you start to encourage more state sharing? How do you start to share those kinds of resources, get states connected with epidemiologists, get states connected with data managers, build the staff capability to be able to do this work? And we have seen states be very energized and excited and passionate about this work. We've had some states thinking about how do you reach those who are suffering housing insecurity? how do you reach those who may be institutionalized? So I think data has been a big part of this. Quality improvement efforts have been very exciting. At CSN, we offer technical assistance and learning collaboratives to states, and we've had about a third to a half of the nation's state and jurisdiction health departments at some point come through our learning collaboratives, and we're looking to reach those additional states that haven't come through yet. But through this quality improvement process and through the framework that we use, which embeds health equity from the start of when you're thinking about what you want to achieve in your state all the way through to evaluation, we have been able to see states make great strides.
Thanks for sharing, Jennifer. Rich, how has Safe States supported state and jurisdiction health departments in addressing health equity?
A lot of the work that we do, does always focus on getting information to our states through our training initiatives, our conferences. 2 consecutive recent years, we had a series of plenary sessions at our annual conferences, and all of them were focused on health equity, awareness raising and providing tools to our members. A specific example of our programmatic work, we're working with a Washington State gender-based violence collaboration on embedding equity into their work through what's called the collective impact framework that looks at disaggregated data, identifies root causes, and identifies partners to work with. We know that more than half of women, almost 1/3 of men, have experienced sexual violence involving physical contact during their lifetimes. Women and racial ethnic minority groups experience a higher burden of violence. For example, non-Hispanic, American Indian, Alaska Native, and non-Hispanic multiracial women experience a higher burden of rape. Our efforts believe that gender-based violence and sexual violence prevention efforts should incorporate a health equity lens to address the factors driving those disparities.
Thank you for sharing that specific example. I'm wondering about the barriers to health equity. We've heard from many states from the Child Safety Learning Collaborative that there are a number of barriers, including access to data and the intersectionality that you've both mentioned. So could you share a bit more about what you've seen at the state health department level? What are some of the barriers to health equity that you've seen?
The barriers are numerous and they're broad. It's a pendulum here, and we made some real advances in the years after the George Floyd incident. And in some places, politics enter into discussions around health equity and anti-racism. In some states, backward, not forward steps are being taken. At Safe States, we conducted a recent analysis of declarations of racism as a public health crisis. Since 2020, over 200 of those resolutions were adopted by jurisdictions over the country. However, some have been repealed. Like anything in public health, a series of challenges were identified in our analysis to doing that sort of resolution. Limited availability of funds to implement change. Some of the resolutions didn't even involve health departments and public health entities. Resistance to change and resistance to so-called liberal woke policies. We have a number of members as we develop our materials that say, hey, I can't use that. I can't use that phraseology. And it's made it difficult to advance the policies that we want to advance. So to advance conversations on race as a public health issue, we do recommend utilizing language that can speak to a broad audience. In essence, as needed, reframing the conversation. We recommend focusing on local and economic issues, including the importance of investing in issues like homelessness and other upstream issues. And importantly, recommend to use an asset-based model that focuses on what's already working, for example, in Black and Brown communities, and acknowledging that those communities have important lessons to teach. This is probably the area that's gotten me most professionally and personally aggravated and annoyed over the last couple of years as we and our allies, try to parse everything that we say. So, I think, reframe the conversation, but don't abandon the purpose of what we're trying to do here.
Jennifer, what are some of the barriers that you've seen in your work at the Children's Safety Network?
Thank you, Rich. I've seen some of the same things that Rich has been talking about. we hear from, 18 to 25 states on a regular basis through monthly topic calls, through individual technical assistance calls, and through focus group discussions around these challenges. And some of the salient challenges are funding, the ability to have the time and the adequate number of staff to build ongoing sustainable collaborations, to be able to address the staff turnover that we see taking place at the state level in the health departments. You have new people. Sometimes people find themselves with only one or two colleagues working on injury and violence and child safety in their department, and that can be a very challenging situation. We also see a challenge where our states are saying we need assistance with identifying those evidence-based practices and programs, while also recognizing that as you build evidence and you do that with higher levels of research criteria, you are often starting with particular populations, but that hasn't been tested with other populations that have been historically marginalized. And we then work with the states to say, okay, so let's be innovative and let's maintain the core components of the evidence-based practice or program, but let's hear from the community members and let's see what works for them. What adaptations need to be made so that this is going to be something that is effective and sustainable in your local community. We also have been hearing a whole lot, and especially over the past year, that there is a real challenge with access to real-time data and access to data around particular disadvantaged populations. With national surveys and with an opt-out feature available, states are facing the challenge that they're not having the same data coming in that can drive their work. So this, I think, is going to be an ongoing challenge that we need to address.
Thank you both for sharing those examples. I would love to hear about what drew you into the work on health equity. Why is it important to you? Jennifer?
Well, I'm the mom of 4 children, so that's a piece of my identity. And also, I'm the child of immigrants. I grew up in a working class community and a sanctuary city. I also grew up in a time of high racial tension in my city, and I was witness to discrimination and racism. And I saw many social determinants at health in play when it came to well-being, development, access to services, whether somebody had transportation, money to pay for a copay. So seeing a lot of these issues as part of my experience, but then as I came of age, you start to reflect on them in a bit of a different way. And I became very interested in what my career would look like and what would call me into a career, and working on social and economic justice, and while also honoring autonomy and independence and the person's vision of how they want their lives to be was very important to me. And so I was drawn into the field of social work. So this has been something that I have seen and been passionate about throughout my life. I am inspired that the conversation is, I believe, reaching a lot more people in our nation today, and that there seems to be an energy and a real commitment to addressing and working on health equity.
Thank you, Jennifer. Rich, how about you?
I entered the field of public health many decades ago, and all the work that I've done, has been to advance policies to improve the nation's health. I think a lot of the work that we do relative to diversity and inclusion is really modeling that for kids. Also a parent of 2 and a grandfather of 2, and you start looking toward the future. On the one hand, so pleased with the progress that we've made fighting against inequities and racism, but almost can't believe that we're beginning to move backwards. Sometimes I refer to a feeling that we're back in the 1950s, and sometimes I amend that to go back another century. So it's all about our kids. It's all about modeling the importance of inclusion.
I would love to hear some specific things that Title V agencies can do to reduce health disparities in their states and jurisdictions. Jennifer?
Sure. I think one of the first places that a state or jurisdiction health department can start is to establish a key leadership role if they don't already have one, so that equity can be championed. This will help to ensure that equity is integrated into the organization, into their strategic planning, operational planning, and in their efforts to secure future funding. I also want to emphasize some of the recommendations we have are to be strength-based, to use a quality improvement approach so that you are always thinking about what is that next step forward, to not become so discouraged that you are thinking that, you're going to lose motivation, but rather what is the one step? And after that one step, what is that next step? And how do you keep going toward that vision? And how do you keep learning? And how do you make things sustainable? So really being intentional about who are the people in the organization? Who are those champions? Are there defined job descriptions? Are there roles? Are there resources so that this work can be strategically embedded throughout an organization or a program, and it can be sustained over time? And that's something that's important when you're looking at child safety systems at a state level. But then as the states are working with the local context, how do you do that same process in your schools, in your hospitals, in your health centers, in your home visiting sites, in your youth programs? You don't want to have this so tied to 1 year of funding that all this good work then does not carry forward. So that's a big piece of this work that we're doing. The other thing is making sure you're working across the social ecological model. So how are you going to be doing the work from the youth, the parent, the family perspective, right up through the organizational perspective, having good organizational policies or new policies in place, up to the societal level? How are you going to be educating policymakers, ensuring that you have coalitions that are working well, or even developing new coalitions because they didn't exist in your state? And then making sure that there is a feedback loop and that you have this continuous analysis of what's going well and where are those gaps. And I think having the humility, the patience, and the kindness with one another are critical to continuing to advance this work.
From my perspective, relative to Title V agencies, they can conduct equity reviews of their programs and policies. They can review screening and referral processes to ensure that they're equitable. Authentic community engagement is so important, as is promoting and providing ongoing implicit bias training for providers. One big thing that many organizations that have been focused on a particular issue, in our case, injury and violence prevention, is the increased focus on multi-sectoral work, on so-called upstream approaches to public health, and realizing that housing, education, absenteeism in schools, it's all tied together. So I think that's the most important thing when we're talking about these equity-related issues is, don't just focus on your silo. Make sure that we're partnering and working with others, because, we need a whole community approach, and we definitely need to involve the community in those decisions. I mean, that's something that I think is obvious to all of us. And then just to restate a goal of Title V is to provide family-centered, community-based systems of coordinated care for children with special healthcare needs, as well as supporting an increase in health assessment and follow-up diagnostics, especially for low-income children. So there's a lot that those agencies can do to promote and reduce health disparities.
Thank you both. Let's end on that sentiment. Rich and Jennifer, thank you so much for sharing your expertise on this topic and for spending some time with us today at CSN. Thank you.
Thank you.
Thank you.
Thanks for listening to this conversation from Children's Safety Network. If you are interested in learning more about how CSN is advancing child safety across the United States, visit our website, www.childrenssafetynetwork.org.